It is now my pleasure to introduce our special guest speaker for this event. Neal Blewett became Minister for Health in 1983 with the election of the Hawke Labor government. As Health Minister, he oversaw many important reforms, such as the implementation of the Medicare Universal Health Scheme, the Disability Services Act 1986, a drug offensive which included tobacco smoking and alcohol, and the first national strategy to combat HIV/AIDS. The strategy included major education initiatives and advertising campaigns, and the implementation of anti-discrimination legislation for those living with HIV/AIDS. A very important aspect of his role as Health Minister was to actively engage with the affected communities as valued and equal partners in addressing the myriad of health, social and political complexities with respect to HIV/AIDS. This model has served Australia and the community well and stands as a beacon of best practice on the international stage, and remains a unique partnership of government, community groups, researchers and clinicians. In 1994, Neal Blewett was appointed Australian High Commissioner to the United Kingdom, as which he served until 1998. At the same time, he was on the Executive Council of the World Health Organization. Returning to Australia in 1998, he became President of the Australian Institute of International Affairs and a visiting professor at the Faculty of Medicine at the University of Sydney. In 2002, he was appointed as President of the Alcohol and Other Drugs Council of Australia. Please would you put your hands together to warmly welcome this outstanding Australian, Dr. Neal Blewett.
Thank you, first of all, for the invitation to address you on this AIDS Memorial Day, and also to thank you for that very generous introduction. Zero discrimination, zero no new infections, zero no AIDS-related deaths. Now, they are extraordinarily brave and extraordinarily challenging ambitions. Let's have no doubt about that at all. First of all, zero discrimination in treatment. As Richard has just pointed out, discrimination is an extraordinarily complex issue. It's not just simply public attitudes, it's internal attitudes. It is a complex issue which we faced from the beginning of the AIDS epidemic. Indeed, in the early days, when ignorance and fear compounded public attitudes, then there were some unforgivable acts of discrimination. I think the situation has much improved, but I don't pretend that it's gone away. And I echo Richard's view that we have to challenge and confront every instance of discrimination or stigma that we encounter. Secondly, zero no new HIV infections. We're going the wrong way on that in Australia at the moment. In the last year, we had 1,525, I think, new infections. That is a 10% increase on 2011. So we've got a big challenge there, because we are moving in the opposite direction to the zero ambition that we have. It's partly, I think, a reflection of our very success, that the very success with the antiretroviral treatments have turned AIDS from what it once was, a virtual death sentence, into a chronic condition, which is now manageable with all the new drugs that we have. But it's still a chronic condition, and we still have, particularly with new young cohorts coming on, we have to convince them of the needs of the preventive strategies. I think in Australia we need a new preventive strategy, a new national livening up of the campaign. Because as each cohort comes through, they almost need to be re-educated again. Thirdly, zero age-related deaths. There we are moving in the right direction. these have fallen dramatically in recent years. And so we're on the path to success there. Now, of course, there was a point in time when there were no seroconversions and no AIDS-related deaths, because there was no HIV and no AIDS. And that's only 30 years ago. Roughly a generation ago, this disease hit our society. Now, for those of you under 50, I think that's about the right one, for those of you under 50, then HIV/AIDS has been an essence of your environment for the whole of your adult lives. It's been there. You've had an awareness of this danger lurking around because it was a condition that by that time had been publicised and people were aware of. But for those of us over 50, it was quite different, because this disease came out of an entirely blue sky, came out of left field, and the impact was such that many of us can remember when we first encountered HIV/AIDS. I can remember very clearly, it was on March the 12th, 1983, in mid-afternoon, I was brought to confront the question of HIV/AIDS. We'd been sworn in as a Hawke government on the day before, and on that day, some 20 or so public health officials from the Commonwealth Department of Health came across to Parliament House to brief the new minister on all the problems he was going to have to face. And they had two great fat volumes, which we moved through hour by hour. And somewhere in mid-afternoon, in the folder, they raised an issue of a thing called GRIDS, Gay-Related Immune Deficiency Syndrome, GRIDS. And they explained to me that there'd been groups of homosexuals in the United States who had come down with odd sorts of cancer, dangerous forms of pneumonia, and they all had in common compromised immune systems. And I said to them, what causes it? Oh, we don't know. Is it environmental? Some of my advisors thought it might be environmental. Is it bacterial? Is it viral? But we had no answers on that March day in 1983. In fact, there wasn't much sense in that meeting that we were on the verge of one of the most devastating epidemics the country was to face. 2 years later, by the end of 1984, it was clear to all of us that we were faced with the most dangerous disease that this country had, the most dangerous epidemic, in fact, that this country had encountered since the flu epidemics after the First World War. So that was the situation, as I say, at the end of 1984. Now, in the next 2 years, between 1984 and 1986, there have evolved a distinctive Australian approach to the disease. We did not follow the usual medical approach to an epidemic disease, which is control and contain policy managed by doctors. Instead, over those 2 years, evolved a policy whereby we would develop a cooperative policy between medicos and the affected groups. In the first instance, mainly gays, but of course also haemophiliacs, and later drug users and sex workers. And what we did, and again it wasn't an off-the-cuff thing, it developed over 2 years, what we decided was that we would entrust and fund these community groups with the responsibility for educating their own community. That is, they would become an arm of the activity to control this epidemic by being responsible for developing education strategies, for developing education materials, and that became the distinctive policy which has really evolved ever since in this country. Now, it was not easy, and it was controversial all the way. First of all, we had to persuade the states who run the health systems, we had to persuade them that we would give them money for HIV/AIDS, but half of it had to be spent by the community groups themselves, had to be allocated to the community groups for preventive and strategies for controlling the disease. Not all the states were on side. In fact, Queensland refused to accept the money. It's one of the first cases where Paul Keating's dictum of you should never come between a premier and a bag of Commonwealth money didn't occur. Joachim Peterson wrote to me and said, "We will not fund this low and disgusting lifestyle." So we were faced there. The other states, after some persuasion, we got the other states on side, but not Queensland. We got around this problem because we wanted to get the money to the Queensland AIDS Council to fund similar programs that have been done in other states. We got round it by using the Sisters of Mercy in Brisbane as money launderers. We paid the money to the Sisters of Mercy, and they then passed it on to the AIDS Council. Now, again, I've got to say that had some problems with the states, but it wasn't all lovey-dovey with the gay groups and other groups themselves. I mean, there were tensions between us. For instance, I can remember here in Victoria, once you begin to accept Commonwealth money, there become bureaucratic requirements. And some of the organisations here were a bit unhappy about some of the bureaucracy that was being imposed upon them. So we had to resolve that. And of course, during the history of the epidemic, there are always tensions between governments and these groups working at the ground level. I remember, really, I suppose, each time there was a medical breakthrough, understandably, there arose new tensions. For instance, once we discovered it was a virus, we had the problem of the blood banks. Once we discovered a test for HIV, we had the issue of whether to test or not. Once we learnt of the heterosexual transmission of AIDS in Africa, we had the Grim Reaper, the problems that flowed from that. And of course, as we discovered effective treatments, AZT and later antiretroviral drugs, there were tensions between governments and groups about the cost of these drugs and the quick access to these drugs. Now, but that became the policy, those were the tensions. I just want to say a little about the personal factors that led me as one of those involved in making these policy decisions. What sort of things influenced me to that sort of policy? And I think of 4 particular personal encounters. First of all, there was meetings with young inner city doctors, harassed, overworked, encompassed by the tragedies of young men, particularly with this new disease, and they had no medical solution. They told me, we can deal with the opportunistic infections, but we can't deal with the underlying problem. Medicine at the moment hasn't a solution. You've got to educate people, you've got to get preventive strategies at work, and we suggest one of the best ways of doing that would be to get the groups themselves involved. So I remember these young doctors, both in Sydney and in Melbourne, telling me this as we explored ways of how we could get the program going. A second major influence was we had an AIDS summit of all the health ministers in Australia in October 1984. I had wanted to bring representatives of the haemophiliac societies and the gay groups in. Queensland vetoed that, said they wouldn't come to the conference if that occurred. So I met the representatives of various gay organisations on the sidelines of that conference. I can remember from Victoria, a very strapping pair, Phil Carswell and Adam Carr, and Lex Watson, I think, from New South Wales. And one of the things I recognised that day was that these people knew much more about HIV/AIDS than most of my advisors, and certainly most of the other ministers I was meeting with on that day. So that was a second factor. Thirdly, in Christmas, New Year, 84-85, I went to the United States, and I saw there 2 different systems of trying to deal with this problem. In New York, there was a doctor-dominated, rather authoritarian system whereby contain and control was run by the medical profession, and there was a considerable alienation among some of the groups affected. In California, the opposite was true. There you had a medical community cooperative group, and that seemed to promise much more. That was a third. And fourthly, my senior advisor, Bill Botel, who had very good links into the gay communities, convinced me that these community groups could do a much more effective and less inhibited strategy for AIDS prevention than could bureaucrats or doctors. So those things came together and helped to influence the decisions we made. As you all know, of course, our efforts were not that successful. It was a slow process, and of course we lost many members of our communities, and we remember those, of course, today. We remember them in the quilts that were established. We remember them in the candlelight vigils that I remember attending during the 1980s, and we remember them in our hearts. I know a number of my students I taught at university 5 or 6 years before, who went down and died of this disease. And that's one of the things we have today is remembering them. But also the other side of that is the triumph, the real achievement of the groups that work to contain this disease in the community. All of them. And one of the things I think it's already been noted, these groups could not have dreamed of the recognition, the authority that they possess today as a result of very, very difficult years of very, very hard and very demanding work, much tougher than being a minister there on the coalface of the HIV/AIDS epidemic. Finally, I just would like to say that I have been terribly impressed by the contribution Australians have made to the global fight against AIDS. Many, many Australians have gone out and taken the Australian experience to countries which are much more seriously affected than we ever were by HIV/AIDS. They've done that not in a kind of boastful, yes, we know how to do it way, but sensitive to the needs, the cultures, the social customs of these various societies. And I would like to thank all of those for that contribution. And that is, of course, where the biggest challenge now lies, to try and contain this epidemic, particularly in many of the developing countries in our own region. And so I thank you again for giving me this opportunity to speak, and I thank them very much for the contribution they're making.
Dr. Neal Blewett, ladies and gentlemen. We do have a small presentation that we'd like to make to you, but before we do that, I'd like to let everyone here know that Dr. Blewett has celebrated his 80th birthday last week. So I think it would be remiss of us not to thank you by singing you a certain song. Happy birthday to you. Happy birthday to you. Happy birthday, dear Neal. Happy birthday to you. Hip hip. Hip hip. Hip hip. Thank you. Thank you.